superior because they tend to be able to take more time with you. And I used to see a nurse practitioner before she retired. I just think there are some wonderful ones. And even in the NAMS, the resource that I quoted, those are,
Yes.
they're going to be nurse practitioners in there as well. So when I try to say provider, because I really do respect that there's doctors, but at the end of the day, I mean, I'm probably more partial to somebody seeing a nurse practitioner who can take that time and really be with you, as opposed to a doctor. And again, I'm not saying that you can't have a good relationship with a doctor, but just don't discount that at all, because that could be a excellent relationship. And even if you still had a gynecologist, it's still a great relationship to have, because you really need somebody during this time who has the time to sit and talk to you, because this is really, again, I mentioned it before, medicine doesn't really honor education and time with the patient. You are rewarded by procedures or volume. And if you aren't doing one of those, then you literally can't make money in medicine. You can't make money by sitting down and spending 45 minutes with a patient to talk about menopause. And that's, unfortunately in my practice, I've had to switch from not being, I can't take insurance anymore because I can't afford, I want to provide that service. And I did that for almost 10 years, but you just can't do it.
And I hear you saying, thank you for that. I think many of us are nodding our heads and in agreement. And when you speak about nurse practitioners, I know I had one. I was my husband was in the military for 20 plus years. And my clinician was an NP. And I was so fortunate. And when because of the time that the NP will take, the courtesies that they often take with you, and not to say that doctors don't, but generally speaking, my NPs were off the chain and still are. I still have another an NP where I get my GYN care, and I absolutely love her. So I'm glad who I'm not sure who that was that dropped that into the chat, but you're absolutely right. And if you can't find joy in some other areas or other clinicians, perhaps start looking at your NPs. Do not forget that.
100. Yeah, I would even say start there.
Yeah, okay.
Because no, I mean, like I said, I think I've worked with nurse practitioners and midwives, in particular, midwives when I was doing high risk OB. And I love that, because then, they took care of the patients, they spent that time, they gave them everything they needed. And then when they had issues, I would, take care of that part. But I just knew that the patients really, they got so much more seeing the midwife than they did seeing a doctor, wow. Especially while you're pregnant. I would 1000% consider that.
Amazing. Thank you. I'm gonna.
Yeah, I just wanted to jump in and say thanks to Sue, who did put that comment in the chat, because that's been my experience as well, having a nurse practitioner, having someone to go to. And when Janine, you were talking about connecting or, looking at and collecting the breadcrumbs and connecting the dots, it's beginning to sound like, particularly around this topic, that they're probably the team approach, getting information, because it seems like not one particular profession has all the answers. And so I'm just, feeling like you're coming to the clinician with a lot of anecdotal type of symptoms and things happening to you. It seems like it needs to be a team to help pull all that together to make it all add up and make sense.
Like a medical home. Yeah. Cheryl, actually, the mic is turned over to you right now.
Oh, sure. Okay, I can ask the next question. We're starting to hear more about heart disease, cancer, and their relationship to estrogen. And you mentioned one myth in your book that's often discussed: taking estrogen during perimenopause, early menopause, will increase the risk of breast cancer. What is the reality?
That is not the reality. So, it can be a controversial topic because it's been so ingrained in our head, like people really believe it's a fact. But the fact is that you know, even in the study that they touted as, oh, this is the reason why we're going to take everybody off of estrogen. Even when you go back and look at that data, if you stratify that data for perimenopausal women, literally the women who took estrogen alone, not estrogen with progestin. And also remember that the estrogen that they were taking was a synthetic estrogen. And I'm not saying that there's a significant difference per se in terms of cancer risk. We don't really know in terms of estradiol, meaning our more bioidentical estrogen versus a non-bioidentical. And all bioidentical means is that it has the same kind of chemical structure as the hormones that we make as a human. So the estrogen, for example, in Premarin, which was the type of medication that was used, that came from the urine of pregnant horse mares. So that's the chemical. It's similar to human, but it's not. So anytime you're going to, first of all, take estrogen, I recommend you take what is considered bioidentical. Bioidentical doesn't mean you have to go to a compounding pharmacy or go do something woo-woo. It's literally like an estrogen patch. That is estradiol. You want to take the hormone that has the same chemical structure as, you know, you have